It is going to prove to be a very lively discussion as the two questions really frame that, it does offer promise, but also how do we ensure equity, access, and make sure that personal choice is reflected, as we heard in the questions that set this up. I'm going to have the panelists introduce themselves briefly, both tell who you are and how you came to this issue. And I'm just going to, my introduction has been made, but I will just talk about how did Keystone come to this issue. Keystone is a nonprofit organization that was founded to drive actionable and shared solutions to tough issues across environment, energy, health, education. Really, we don't come to these discussions, debates with a position. More so, we come to ensure that diverse voices are represented and that there are shared outcomes that are actionable and can be followed up on. And with that, Bruce.
Sure. I'm Bruce Conklin. I'm at the Gladstone Institute's UCSF and the Innovative Genomics Institute, and I'll talk more about what I'm doing later.
Good morning. My name is Shakir Cannon. I'm the co-founder of the Minority Coalition for Precision Medicine, which is a self-funded organization that I started alongside my partner, Michael Friend. And we kind of started it to really engage, minority groups and really engage more participation. One of the main reasons why I'm so excited about CRISPR is because I myself have sickle cell disease, which is a genetic blood disorder. Within the sickle cell disease community, there's a real, firm understanding of that there seems to be not much hope. We seem to be losing people who identify themselves as sicklers almost on a weekly basis. So there's an extreme strong sense of urgency here. Personally, for me, the median life expectancy now is 42 years of age. I'm currently 34 years old. So just knowing that history really propels me to really bring CRISPR to the spotlight. I believe sickle cell disease can truly do that, and I'm very excited to be a part of this.
Good morning. My name is Osagi Obasagi. I'm a professor of bioethics here at UC Berkeley in the Joint Medical Program and School of Public Health, and I'm also a senior fellow at the Center for Genetics in Society.
I'm glad to be here. My name is Rosemarie Garland Thompson, and I'm a professor of English and bioethics at Emory University. And in that role, what I do is I'm a writer, I'm a researcher, and I'm an educator. And the perspective that I bring to, as we say, knowledge making and dissemination is to think through the stories and the images and the words that we both receive in being acculturated in the place and time where we're acculturated, and how those words and stories and images shape how we think about the human variations that we think of as illness and disability.
Morning. I'm very excited to participate in the panel. I'm Mark Walters, Director of the Blood and Marrow Transplant Program at UC San Francisco, Benioff Children's Hospital, Oakland. I'm a pediatric hematologist, and I've had a lifelong interest in hereditary blood disorders like sickle cell disease. In the early 1990s, I led a multi-center clinical trial that showed that bone marrow transplantation is a potential cure for this disorder. But unfortunately, we've applied that cure to very few individuals affected by this disorder. So I'm particularly keen in putting a lot of energy and time into exploring CRISPR-Cas9 reagents in hematopoietic stem cells of persons affected by sickle cell disease as a potential universal curative treatment for this disorder. So I think that's why I'm here today.
Great, thank you. Genome surgery is a new term for many people, so Bruce is going to actually go through a brief slide presentation to talk about the distinction, what it is, to frame the conversation and the questions. You'll hear some of the questions we're going to ask today are similar to what were asked yesterday, but again, have a variety of perspectives to really give their perspective and the important to really inform this conversation. But again, encourage you to make sure that you put your questions on the website as well. Bruce.
Okay, great. So I think there's slides. Do I just do this? Okay, great, thanks. So just to frame this a bit, the area that I work on is a human iPS cells, stem cells from skin cells, and applying CRISPR technology to that. And it's interesting to note that it was really only 11 years ago that Shinya Yamanaka invented or discovered that you could make these stem cells from skin cells. And now, really, it's only 5 short years since the seminal discoveries of Emmanuel Charpentier and Jennifer Doudna. It's rare in science that really breakthrough technologies happen at this magnitude, and it's rare that just 2 papers actually listed below are the 2 that actually mark both of these discoveries. And these discoveries are remarkably disruptive on their own, but then when combined together, they're particularly powerful. All of this is also going in the background of genome sequencing that is actually increasing in power at a rate which is actually about 3 times Moore's law. So if you look at the top white bar, that's actually Moore's law. This is a log scale here of the power of essentially what genome sequencing would be like if it was following Moore's law. And the green is actually the price of sequencing a full genome shown here, showing that it's actually beating Moore's law. Everybody knows how disruptive computing has been. Think about how disruptive this is. Essentially, anything that you can turn into genome sequencing now becomes thousands of times more powerful than it was just a few short years ago. And this is sort of background material, but I think that we've got multiple disruptive technologies working together. The impact on CRISPR and stem cells, I should add, is really the big public health story is probably going to be the discovery of disease mechanisms and new drugs. But what I'm going to be talking about is genome surgery to cure rare diseases today, and I think that that's because it's a topic of the story. But I think as a public health impact, we're going to have better drugs, better therapies in many ways that are not just cutting the disease gene. When we think about genome surgery, the real problem that we face is that there's about 7,000 different genetic diseases, and the common mutations where we could think about as sort of a business model, as it were, for a one mutation hitting, being sort of editable in such a way that many people could have it, is actually very, very few. Most of the human genetic disease, the vast majority of human genetic disease, is quite rare. And I like to think about this as more of a surgical approach rather than a medical approach. And I think that a lot of people are thinking about it, the biotech companies are thinking about it as a medical one. But I'd like to just point out that there's a very different sort of social context for medicine and surgery. For instance, we often refer to physicians and surgeons. The Columbia University School of Medicine is actually Columbia College of Physicians and Surgeons, not or surgeons or whatever. And the reason is because physicians, came from very different background than the surgeons. The physicians actually were the bloodletters, and they gave you leeches and so on at the turn of last century. Whereas the surgeons actually came from a completely different route. They were actually the barbers, the people who carried knives. The other thing is that in modern day, that there are very different approaches to disease. Medicine really focuses on inventing billion-dollar drugs, where surgeons actually use devices to try to cure very rare diseases. The first heart transplant was done by a surgeon. The first kidney transplant done by a surgeon. They didn't worry about how to monetize the 10th heart transplant. They just did it to see if it could be done. And I think that that analogy here is actually much more applicable, especially to rare disease. So I should also say that genome surgery is only to very specific tissues. It's not to it's not a germline type of edit, so it's not inherited to the next generation. It is treating very specific disease, and we make an effort not to go germline with what we do. And also, I think that the fact is that when CRISPR is delivered locally, there are some forms of CRISPR that could cost less than $1,000 per patient. So if one starts to think about, at least that's obviously the medical costs of delivering it would be more than $1,000, but the actual product that is delivered is very, very inexpensive potentially. And so that's a democratizing aspect and pertinent to this discussion. What is genome surgery? You can think about excision, insertion, restoration. It's essentially shown here. You can see this at a DNA level, and really the easiest for us is actually the excision, to cut in two places, and it's remarkably effective. In some cell types in vivo, we can actually see 80% excisions, whereas it's more difficult to insert something and most difficult, I think, to make single base pair changes. But that's just now. How do we envision this in the future? And this is close to my last slide here, is we imagine sequencing somebody, then knowing what the actual reagents are, as indicated by the A, B, C, D there, and then actually potentially testing this out in cells that are derived from the patient via stem cells, but then actually taking out the diseased allele and potentially curing patients. I'd note here that we can grow cells, neurons, for instance, cardiac cells, many other types of cells from patients now in a very, very robust fashion, and this allows us to test that. So with that, I just would like to close and just say the challenges that go forward that I see them are really specificity of the editing, delivery into the right cells, and then models of that are for treatment that will allow treatments for many rare diseases, and to do those at an affordable cost so that it can actually be available to the most possible people. So thank you very much.
Thank you. So great. That starts to set the frame, but again, I think with every answer comes more questions. So we're going to start doing these questions, and we're already starting to get some good questions on the website as well. But I'd start with, as we think about this and think about the accessibility, where is that line between a cure and an enhancement?
Well, I think that for the initial, the proof of concept studies, we're going for cure, because we have 7,000 diseases to choose from, and we want to have a proof of concept which is going to be a cure, at least at the individual cell level, so that they are completely back to normal. But I think that in reality, that there are many many therapies that are being proposed, which would be just amelioration of the disease, and those are also completely valid and approachable, especially some of the types of diseases I showed in that pie diagram that are kind of the ones where you treat many diseases with one particular thing. Those are often things which are going to be partial cures, essentially.
And I think yesterday we directed to one question, but I'm going to actually open it, most questions, to all panelists that want to answer it. So just let me know if you want to jump in as well. I think as we move on, this is about, when we talk about disease, it might be easier, but it is about eliminating variation. And so what do we lose? And Rosemarie, I'll probably start with you. What might we lose as individuals or communities as we edit variations?
Well, I'd like to start with the question that Michael posed to the audience, and to think through what kind of human variations we want to eliminate from the world, and what kinds of people we want to be in the world. And these are ethical and social justice kinds of questions. And I think what we want to do is to think about, the way I talk about it, the work of language and story. So genetic disease, if you will, is a story. And so when Michael asks us if you could eliminate a genetic disease from someone, I think, in your family, would you do it? We overwhelmingly say yes. And the question that we want to ask, coming from, if you will, the community that I represent as well, and that is the community of people with disabilities and, more recently, the community of people with rare genetic diseases. And mind you, I would have never thought of myself as someone with a rare genetic congenital disease until rather recently. I'm kind of like Greg Simon. Is he still here? In that I have different hands and arms than probably most of the rest of you. But if there are 7,000 genetic diseases, probably most of us in this room have, whatever that might mean, some kind of genetic disease. So what we would want to do is to think about terms and ways of understanding this category that we're thinking of as genetic disease in other kinds of ways, because there's a great deal of variation between, say, the way of being in the world that Shakir is, the way of being in the world that I am, the way of being in the world that all of us are, and think about things such as what kind of quality of life do we have? And how do we get the quality of life that we have? Now, in bioethics, quality of life is measured in terms of disability. But in fact, quality of life, sociologists will tell us this in a minute, should be and can be more effectively measured in other ways. For example, access to education, access to social goods, socioeconomic access. These affect quality of life much more than the human variations that we think of now as these 7,000 genetic diseases that we have. So those are the kind of questions that people in my community, if you will, and people in my life work ask.
Excellent.
I think working with, throughout our previous work, we've worked with a lot of professional organizations, such as the Joint Commission, American College of Emergency Physicians, and really going peer-to-peer, individualized, patient-centric approach to bringing this forth. I think this is an incredible opportunity, again, as I say, for sickle cell disease. For many reasons, I think, given the current environment that unfortunately our leadership 45 has kind of put us into, kind of separating, blacks and whites, and tensions are very high. But if you can illustrate that, CRISPRcon has invited a sickle cell disease patient to really participate on the panel, something like that is very progressive and very thinking outside of the box, and just highlighting that not only will kind of bring, tensions to slowly come down, it shows that, as Americans, we can truly work together in a positive way. And noting that it was the first molecular disease discovered. So just knowing a lot of that history and trying to do something positive, unlike what we've seen historically for African American populations, I think this is a tremendous opportunity.
Well, that sort of leads us to another question about access. So from the slides, the potential cost of using the technology might be low, but the medical costs maybe around that and surrounded by that can take this out of the hands of many people and maybe not make this as equitable or accessible or affordable, even if we democratize the technology. can people that need this really get access to this? They open that to all.
Well, yeah, but I do think that we should focus the discussion on the technology and not talk about the entire healthcare system, because really we're dealing with surgical procedure, and I think that it's true that for if a procedure is super expensive, it's going to be more of an issue getting it to people than if it's inexpensive. But I think that in reality, I think that the access to healthcare is a huge problem, but is completely independent of CRISPR, right? Access to essentially doing any kind of healthcare, even emergency room services, are a huge issue in this country, but is completely, I mean, you can have that discussion without CRISPR. The issue is, what does CRISPR bring to the conversation? And they're related, but the problem is not CRISPR, or it doesn't make things worse or better in some sense. I think we do have to think about bringing treatments that are the most affordable and not worry about the profits of companies. But regardless of what we do, the healthcare system is broken and needs to be fixed. And I think that's a separate conversation and is completely independent of CRISPR.
Totally fair. And I think it is related. And so I think really the question is, how do we ensure equal access? If this is about genome surgery and equity, I just open it up to other thoughts.
I was just going to give an example of what the challenges are by illustrating how we might pursue this in a blood disorder like sickle cell disease. So it's a rather complicated treatment, and begins with extracting a hematopoietic stem cell from an individual affected by the blood disorder, taking that organ system, the blood stem cell, outside the body, introducing the reagents into the stem cell, and then correcting the mutation. And then after that manufacturing procedure, returning those blood stem cells back to that person, getting them into their circulation, and then correcting the underlying disease. Now, many stem cells, including the blood stem cells in the body, are quite resistant, for very good reason, to changes in their DNA. If you change the wrong DNA in a blood stem cell, that could cause leukemia, either by activating or suppressing the wrong kind of gene. So it's very difficult to get a significant number of the stem cells corrected. So I think the first step in any kind of therapy like this is showing that it's safe, that you can do the manipulation, and there's the feasibility of getting the blood stem cells back into a person and show that they don't cause leukemia, at least in the short term, and that you modify enough of the stem cells to have a positive effect, maybe not a cure, but to show that you're on the right track, and subsequent improvements in the technology will get us to where we want to be eventually. That said, you can imagine that sort of incredibly intensive, expensive therapy is not going to be delivered universally. In fact, it's probably going to be delivered in very few places to start with. And in sickle cell disease in particular, as Shakir knows better than I do, there may be 100,000 affected individuals in the United States. In Nigeria alone, we know that there's at least 1 million, probably many more affected individuals. And we are just not going to be able to get this therapy to where most of the affected persons reside in the world in the near future. So the technology that's required should go hand in hand with the World Health, public health application of this is going to require an incredible public investment to get the therapy to where most of the persons in the world reside.
And I'm sorry.
I was just going to note that I think the Center of Medicare Services, of which we have, our organization has relationships with, would agree, given the fact that they're transitioning kind of from a fee-for-service model more to a value-based driven model. So I think highlighting CRISPR and gene editing technologies as a value-based discovery, if you will, I think that's another reason that groups like CMS would kind of get behind this.
Okay, so-
And, you know, I agree with the previous comment about it's important to make sure we have, we distinguish our conversations about the technology on the one hand and healthcare on the other. But on the other hand, I think it is important to also see that there are moments of synergy and connection between the two, to the extent that, you know, whenever there is a new biomedical development, there's a lot of excitement. And oftentimes that excitement tends to reinforce this narrative that we see about disease being something that is located in the body. That's something that is primarily an individual problem. And that sometimes can obscure the broader public health conversation that we can have about the social determinants of health. And so this is just to say that, you know, I think it's important to, on the one hand, to continue to pursue understanding what CRISPR can do, what this technology can offer us. But on the other hand, being aware that the vast majority of disease can be caused by environmental and social concerns, and that it's important to make sure that when we're thinking about how we commit resources and dollars, do we continue to go down a path of funding these kind of individual initiatives for more technological development, or do we have a broader conversation about what can we do to change the way society is organized to have the biggest public health impact on the greatest number of people? And it's just, I think oftentimes, you know, we think of these as either or conversations, and hopefully we can find ways to keep these conversations going together in parallel.
Great.
To follow up on what Osagie is saying, it's very important for us to think not only about the kind of micro use, if you will, of CRISPR in the promising ways that you're describing and that Bruce is describing, because those are really important and ethical kinds of undertakings, but also to realize that some of the larger social implications that might come out of these kinds of technologies, these kinds of tools, and of course they're not really tools, they're medical procedures, and to think about the work of gene editing in general to standardize communities, to make us be kind of all the same, which we think of as normal, but it really is a matter of sameness. And the outlines of that sameness are determined by people who have particular experiences and positions in a society, and the values that determine that kind of sameness that we will end up working toward in lots of areas, medicine being only one of them, may not be the kind of sameness that we actually want. And so, especially in future generations. And so we need to think through that by listening to the perspectives of people who don't share those samenesses. And there are plenty of communities. They've been mentioned here, say, communities of deaf people, communities of neurodiverse people, communities of people with disabilities, communities of all sorts of diversity, if you will, human variation. And I was struck yesterday by one of our questions at the beginning in which we were asked what should scientists keep in mind in talking to the public. And so this kind of division between the public and scientists is itself complicated. And I right away put in, pay attention. And it never flew up there, but what did fly up there over and over and over again was explain, 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 explain. And I wondered if this was not a kind of response that understood that it was the scientists that were doing the talking, and it was the public that was supposed to be doing the listening. And I wanted to call attention to that because I think maybe part of what we're talking about here is turning that one around.
Well, and that leads to a great next question is, we heard the importance yesterday of public engagement. Pastor Mike was great about saying we need to have active voices as well as constructors. And so as we think about the technology and the conversations we should be having concurrently, how do we ensure all the important voices are engaged as these efforts are moving forward? Shakira, I'm going to start you with that one, and then.
I think the way that our approach has been in the past. We've held community engagement, capacity building, and partly on economic development. So we try to inform, we work with a lot of faith-based leaders in a lot of our work. We kind of see faith-based leaders as trust agents, if you will, for a lot of various different minority groups, particularly African American. So part of our project, of which we're calling the Freedom Project, is to just kind of hold conversations. We have great African American and minority scientists, because the idea is that if we're kind of instructed, if you will, by a scientist that kind of looks like you, you're going to kind of more gravitate to the knowledge that you're hearing and be kind of more accepting of that. So we have great scientists like Dr. Tashaka Cunningham and Dr. Hadia Green, who has been excellent in providing this information with our trust agents in the faith leadership community. So I think taking that real grassroots level community engagement approach, it has been truly effective. And working with the PGA group out of Harvard, with Ting Wu and Dr. George Church. So just having such relationships with such high-level scientists that are tremendous in CRISPR and genetic technology information, that approach has been truly effective.
Great, thank you. Other thoughts?
So I'm in the trenches, and I am listening to what people want, and they want better treatment, and they want a cure, and they're saying it loudly. And so, and by and large, the families that come to me have exhausted all our alternative therapies. So they're desperate. And so this is, we're trying to follow that pathway. Because like all of us, we want to reduce suffering. We want to find a path to a cure, to improve outlook and quality of life. So we're going after this full-fledged, and it's going to be difficult. Funding is always challenging to develop these novel therapies, particularly in underserved populations, to be clear. So that's what we're doing. And yeah, that will reduce the variation, but I hope it's balanced by reducing suffering, improving outlook, and giving hope. And so that's really why this is so exciting, this new technology, because again, this is something that we might be able to apply universally for the first time. This is really a momentous time.
And of course, if there are 7,000 distinctive, if you will, ways of being or potential ways of being out there in the world, there's going to be a great variety of what we think of as suffering amongst those various ways of being. And that's, I think, the conversation that many of us are asking about.
So yeah, I could speak to that. I think you're absolutely right that there's a kind of a variety of disease, and I think that what we're focusing on first, and I think just about everybody's focusing on first, are the severe forms of blindness, for instance, crippling and deadly neurologic disease that are where the patients are not just equivocal about this, but actually quite enthusiastic and about wanting to be involved in something like this. And also, I should add, my comments earlier about I think that the problems that are faced with this technology are shared by all all sort of complex medical interventions, and I think that to some extent, I think that it's brought forth more because of the kinds of potential impact that this has. But in fact, I don't think that it's, in terms of the total medical cost in the United States, we're talking about more than a very small fraction, actually. And then if you want to talk about genetic, really an impact on genetic variation, the major impact is going to be on pre-implantation genetic diagnosis. And there's been a lot of discussion about germline therapy, and that's all very important. But I think that pre-implantation genetic testing is going on. The biggest story of this, perhaps, in this whole thing is not CRISPR, but in vitro fertilization. Once in vitro fertilization happened, essentially, you go to a hospital, for instance, in a Jewish hospital supported by the Jewish community in Manhattan, and you look for Tay-Sachs disease patients. You go to Tay-Sachs Clinic, and the only people you see there are Palestinians. That's because the Tay-Sachs virtually is almost have been eliminated within the Jewish community, and the genetically related Palestinian community still carries it. And that's an access to care issue,
Right.
and it's perhaps a genetic diversity issue. Perhaps the Jewish population is less diverse because they don't have Tay-Sachs any longer, or very much. But I think that's I don't think that. I think that actually they're very happy that they don't have that disease as much.
Blindness is a really good example because it's one of the iconic conditions. We have a long history of what it means to be blind and what blindness actually means in our culture. And there's a wide variation, not of severity, but rather of positions and opinions about whether blindness is a condition that we want to eliminate from human experience. For one thing, many of the conditions that we think of as disabilities, all of us will evolve into over our lives. So if we live long enough, we'll all become at least vision impaired, as they say, if not blind. If we live long enough, all of us will become hard of hearing or deaf. And people who begin life blind or deaf are actually great resources for the rest of us in figuring out how to live in a world not built for us, developing the skills that we need in order to be that way in the world, which we all hopefully will end up being. And so to think about these target conditions, if you will, in these ways, and I'm sure there are plenty of people who are blind who would like very much not to be blind, but there's a much broader conversation to be had and much broader perspectives than we might be considering in the beginnings of these undertakings.
So do you agree, though, that it should be an option of the individual person who is going blind to potentially avail themselves to a therapy? Or do you think that the community should be able to say, no, you're going blind and that's part of natural diversity?
This is a much, much larger conversation that has to do with the structure of our order, so that, I mean, our social order and our political order, in the sense that individual autonomy, liberty, is really very important. So in almost every case, an individual should be able to give consent, this is how we talk about it in bioethics, and exercise autonomy, liberty, in what happens to them within healthcare situations. But it is complicated by considerations of what might count as free choice, when, if you will, the stories are very compelling about what kind of a low quality of life people will have with these various kinds of ways of being in the world, or conditions or diseases. And so we have to think about that as well. We have to think about the differences between individual good and community good. One great example that doesn't have to do with CRISPR is the use of sex selection abortion worldwide, which is a very fundamental part of reproductive liberty, in the sense that everyone should be able to figure out, should be able to choose what kind of family they want to have. But what's happening, as we know, and this is not CRISPR, but it is reproductive technology, is that the imbalance of men and women in being born into these societies is creating one thing more than anything else, and that is violence. Because it's creating a class of disenfranchised men who are the perpetrators worldwide of violence. So it's much more complicated than just consent and autonomy for individual health care and treatment. And we just need to have those conversations.
Yeah. And just to tag along with that, I think what you're raising is this interesting conversation about CRISPR is kind of diving headfirst into this pre-existing conversation about the difference between rights versus justice, right? So the idea that individually we want to have the ability to determine our individual paths, and we see that often we often articulate that as a right to access certain therapies or a right to do certain things. So this is the liberty interest you're talking about, versus the notion of justice, that is an acknowledgement that not all people are equally situated to take advantage of rights in the way that other people do so. And so when it comes to the development of these new technologies, I think it is a serious conversation to have how do we, in terms of how do we make sure that individuals have the ability to choose what therapy is best suited for them, versus making sure that individual access doesn't necessarily impinge at broader group interests, and how certain individuals, or I should say how certain groups can make sure that they are not, they don't have their life experiences discredited, or furthermore, to make sure that just because there is existence of an individual therapy, that doesn't necessarily, or that shouldn't diminish the public commitment to making sure that that groups maintain their integrity and have their opportunities as well.
Well, those are a good discussion. So we're going to move to some of the audience questions. So as it comes up, I can say the first question that we received or the top question right now is, what are the regulatory implications of defining somatic gene editing as surgery rather than medicine? It lowers the bar for FDA approval, correct? Is that a good thing?
So the FDA regulation of gene editing is actually something which is in question because just only because it's a completely new therapy and there really are no known paths that fit everything. What we are advocating for, though, is that some aspects of the surgical and device pathway be merged with some of the biologics and gene therapy pathway, and there are aspects of both of those pathways which are valuable. It's probably going to be down the gene therapy pathway, but in terms of the main regulatory path. But there are aspects that have been taught that are informative, and regulations that are in place via the surgical pathway that is going to be, I think, potentially make it lower the cost, increase the flexibility for super rare diseases. Most of the diseases we're dealing with, by the time we finish a phase 2 trial, we'll have treated all the patients. So it's not really, there's not a good way to actually move forward with that. But with a surgical sort of approach, one could imagine a rolling thing which could actually be more effective. Maybe, I don't know if you've...
Yeah, our approach in my specific area has been in the biologics pathway and the gene therapy. But admittedly, the FDA is still finding its way, and they were very interested because we were one of the first groups to approach them about how the pathway to approval. So I hadn't even considered the surgical approach, which is very interesting, but assumed that the biological pathway to licensing would be the proper one.
Yeah, no, it will be, but I'm saying that there are aspects of that would
Yeah.
could be incorporated.
Great. We keep referring to the low cost of CRISPR as a democratizing treatment opportunity. However, once the Berkeley versus Broad Institute court battles are over and the patent winner begins charging license fees, won't CRISPR become cost prohibitive?
Well, it depends. I think that could be for some of the larger applications, but for some of because CRISPR is so cheap, actually, the approach that we're taking is that we're giving the CRISPR away, so they can sue us for all the profits that we made from CRISPR. But if at $1,000 per thing, we're going to in medical research, you can actually, you don't really have to actually pay the patent. So we're not at all concerned about the patent issue at this point. The other issue is, I think that the patents are really only for a particular type of Cas9, and there's a whole, there's really a zoo, hundreds of different Cas9s, of which are going to be open access, as it were. So I see the patents as an issue for certainly an important one for in terms of this, because pharmaceutical companies are licensing this for research purposes and so on, and there's going to be some applications which are used in lots and lots of people, but for genome surgery for rare diseases, it's really not a problem, because I don't see it as a problem, because most people are not, at least for the initial things, going to be charging for this, right? It's a totally different model.
So the question of equity, so that's partly how we define this, as sort of how do we make this equitable? The question really is, please define equity. So from each of your perspective, how would you define equity in terms of this? We can start anywhere.
Rather than defining equity as I understand it, I would invite us to think about other arenas besides the medical one, other institutions besides medicine and science that have evolved in Western culture that have addressed equity really quite thoroughly. And I talk about these as being the agreements and the laws and the policies that have arisen out of democratic, egalitarian social orders. That's a little heavy, but and I think some of the most promising documents and agreements to help us understand what equity means in the healthcare and medical science context would be to look at some of the documents that have come out of the human rights movement. So, for example, the United Nations Declaration of Human Rights really helps us understand what equity is by giving us language to think about that in a social and political context. And specifically, one of the documents, the treaties, that is most important in my world is the UN Convention, the Treaty on the Rights of People with Disabilities, which is a very capacious and complicated document and set of points about what equity might mean for people with disabilities. Of course, the UN has conventions on the rights of women, and so those kinds of narratives, if you will, I think could be very profitably brought into these kinds of conversations when we're trying to think about ways of thinking that are beyond or different from a kind of medical scientific way of thinking about people.
I think equity from a patient standpoint, it's just this very thing right here, inclusion of a patient at the beginning of a new technology coming out, such as CRISPR. I think that goes a monumental way. And I also think on the other aspect of equity, just thinking about, the economic standpoint, I believe I read that eventually genetic technologies may be $1 trillion industry. So I think a lot of companies have instilled a revenue sharing model approach to the participatory research. So let's say if I were to be CRISPR'd eventually someday, maybe any revenue that's generated from CRISPR technologies, I would receive a percentage of that sharing through a revenue sharing pool. There's a lot of talk in the several industries about that. So I think there's an economic advantage to this too that we need to consider.
Okay. And then from a provider perspective, as you're providing these treatments, how does it come up for you?
Just briefly, I'd say, just when I think of equity, I think some of these comments are great that have been said before, but I also think about equity for a person who's going blind to be able to be like other people who are, and they desperately want to be able to see, and that would be the equity there, or someone who is unable to walk and is going to be able to walk would be those sorts of things. From an individual point of view, they feel different and they don't like the way they feel different, and they want to be changed. They want a change, and I think that's a different kind of equity. But not to say that it's they're
I totally
parallel.
understand that as well.
Yeah.
I don't want to live with this anymore. So.
Right.
Yeah, so from my point of view, it's pretty simple, actually. The way to achieve equity is that you have a treatment that's safe, inexpensive, and 100% effective. And that's not where we're starting with CRISPR. It's going to be expensive, it's going to be intensive, and it's not going to be available to very many individuals. But I can imagine that with advancements, this could be a treatment that doesn't have to be done in the hospital. It could be done as an outpatient. That could correct all the stem cells, and that could be done inexpensively worldwide. Now there are a lot of steps to get there, so it's a process. So we're not going to start at equity, but it's a goal that I think is achievable.
Right. And to add to his point, though, about expensive, it's not actually expensive because of CRISPR. It's expensive because of all the delivery processes. And the CRISPR part of it is actually cheaper than the gene therapy part, which is the viruses. So actually, CRISPR is not increasing the cost, but decreasing the cost of an expensive thing. So I just want to make that clear, because a lot of people think CRISPR is going to raising the cost of things. He's got an expensive treatment, which is actually the cost is coming down. It's still expensive. But that's
exactly correct.
Yeah, and so in terms of bringing this to CRISPR and what the CRISPR contribution is, it's lowering the cost.
It seems like that goes back to Shakir's point of how do you shift the conversation to value-based rather than that fee-for-service kind of piece. A question that we got is CRISPR-based genome surgery a bridge technology to germline editing?
So like a gateway drug kind of thing. Absolutely. Yeah, absolutely. Yeah. There's no question. I think that but at the same time, I think the FDA is going to be very careful and only approve things which are for very, very serious conditions. But if you talk about a 50-year runway or something like that, for sure.
Great. Did others?
Well, I mean, Marcy brought this up yesterday, and the distinction between what we think of as curing disease and enhancement techniques. We know that that's not going to be, it can't be monitored in any way in a liberal society, and in a way it shouldn't. So I think not very many of us who would want to say we should be not having CRISPR. I mean, it's going to, all of these procedures are going to continue. But we really ought to be pretty clear about a conversation, public deliberation that includes a very wide set of perspectives. Because in terms of the blindness, the people that don't want to be blind are the ones that are coming to you. But what we also want to hear about are people who feel differently about being blind. Because if we only get one perspective, we're not going to be able to understand who we are as a community and make decisions about what kind of a world we want to live in and who we want to have in our human community.
And I think the challenge is, when it comes to germline engineering, if that becomes that comes to pass, then we're not even we're creating the kind of a set of conditions where future generations won't even be able to have that conversation because we've made it for them. And so this is what makes the issue around CRISPR and germline engineering so difficult, because this is a profound intervention into the human future,
Right.
and what the future landscape of humanity looks like.
And if consent of the governed and consent of the treated is a fundamental principle, we really have to think about that.
Well, also think about, but also, I think it's a remarkable statement to think that any existing community or society has the wisdom to determine what's best for all future generations going forward. And for us to even contemplate the possibility of doing that at this particular, social and political and economic moment, I think is deeply troubling. But that's the trajectory where things are going in. So I think we have to have a serious conversation about germline editing and what it means, and what are the responsible, democratic ways to make sure that future generations have say over their own being.
Can I just say one more thing? Gateway drug, CRISPR is a little bit of a gateway drug. In vitro fertilization is the elephant in the room, right? That's when, once in vitro fertilization which is now common practice, essentially the germline editing was going to happen without CRISPR or with CRISPR, essentially. And so I think that, so if we can make it a CRISPR story. I mean, I think there's but therapeutic editing in somatic editing, that is a new thing that we really couldn't imagine before without in sort of a facile way as we're doing without CRISPR, especially for rare diseases. So I think that when we talk about a gateway or something like that, to me actually it's a relatively minor kind of addition to an overall thing, which is in vitro fertilization.
But I mean, and to your point, this is where the rubber is going to meet the road, is when this becomes something that becomes possible in fertility clinics. Right. And we've already seen many troubling examples where certain clinicians, fertility clinicians, have decided to offer certain services to couples who wanted to be able to ensure that they have children with certain traits. And if and when this technique becomes viable in that particular clinical setting, then that's where things get real.
Let's be straight, though. PGD is germline genome editing, right? That's all we're, right? I mean, basically, you can make 25 embryos. You choose which one to implant, and the other ones are edited out. And so it is, in a real sense, that, and that's been going on for years.
Right, but that's selecting a particular embryo out of a group, as opposed to having the embryo and the possibility of editing in or taking out particular traits. That's a level of control that we haven't seen yet.
It is a level of control, but I think for many years to come, that's still going to be the most powerful method.
Again, speaking to the importance of having these conversations now, sort of the pathway we're on. So I think, you know, as Shakir was talking, there is immediate need for some with sickle cell or others that want to be able to use CRISPR technology. What is the timeline for people to have access to when you're thinking about, because I think when I talked to both of you, really we're talking about sort of, we're still in that trials, evaluating what's safe, but there are real concerns about sort of when this becomes available for people to use.
Well, they're
Yeah,
further
so
along.
it's moving very quickly. It's a highly competitive field. This is an obvious target for the technology, so there are many groups working on it, and I suspect that it's not a far-fetched prediction that there will be early phase clinical trials, say 2 years from now. And now and we'll learn a lot from those. I don't predict that there'll be home runs. I don't think that they'll necessarily be curative, but they'll start us on the pathway of how do we use this technology in a safe and effective way. So it's not so far away, actually.
I know that in Europe, they're beginning clinical trials next year, 2018, but I'm not exactly sure about for the US.
And then Shakir, when you're thinking about access to and talking to, you know, Centers for Medicare and Medicaid Services to really get that value-based payment, does it seem like there's a receptivity to the payment for? Because again, that was sort of recognizing it's not so much the technology, and the technology might drive down the costs, and that creates that value-based. But a lot of what gets utilized is what's paid for by a private or a public insurer, generally. How have those conversations been going? What is some of the thinking? Again, not to speak for CMS, but just, you know, sort of those initial conversations.
We haven't really brought in conversations particularly about gene editing, but more so for other projects related to sickle cell disease. They're kind of more open to a more patient-centric approach. So we've been very successful at that approach, but I'm not so sure about how gene editing would kind of flow within the CMS.
Yeah,
realm.
we've pursued with CMS successfully, not CRISPR-Cas9 directed editing, but other more conventional forms of bone marrow transplantation in new populations, particularly adults with blood disorders under this evidence development mechanism. So you can authorize the therapy as the evidence is developed that we either support or not support it as an effective therapy. So there are avenues to pursue. I don't think that's going to be possible in a phase 1 type of setting. So unfortunately, those clinical trials, the full extent of what Professor Conklin was talking about, it's not so much the editing per se, it's all the intensive therapy in the hospital that makes these treatments so expensive. That aspect of the initial clinical trials will probably be borne by the entity conducting the trial. But ultimately, there is a pathway to approval by CMS through an evidence development process.
Great. Well, so as we start to wind down, and we are running out of time, I'd like to open it up to each of you. If there was a question you wish I had asked or somebody in the audience had asked, sort of what is the sort of point or sort of piece that you would like to leave the audience with to inform future conversations?
I would just focus more so about saving lives and less so about designer babies. I do love designer clothing, but I think designer babies is maybe 50 years down the line kind of thing. So let's just focus on saving lives, at least for now.
I like the point about are we listening? Are we listening to the concerns of the public, and are we instituting those concerns into how we approach this translation from a laboratory tool to medical therapy?
I mean, I guess I would, how do we, I guess the question I would add is, you know, how do we, in addition to develop this technology in a robust and thoughtful way, how do we also create the conditions for humility among all the providers to ensure that, well, providers and researchers, to make sure that we are, as we, you know, grab the reins with this incredible approach and technology, that we're doing so in a way that is mindful, thoughtful, and aware of where things can go.
Yeah, and I think it's a tremendous you know, opportunity, this sort of forum and other forums with people with disabilities and rare diseases, to understand their insights and to hear their voices. It gives me a great deal of humility dealing with these groups and knowing the kinds of challenges that they face on a daily basis, and to realize just how fortunate we are to be in a time to be able to even think about helping them. It's really an honor, but it's more so when you understand their voices, essentially.
As a result of these Oregon developments, if you will, of what the news out of Oregon in the last few weeks, there have been a number of what I call, wait a minute, op-ed pieces that go like this, and they come from people in, if you will, my community, and they've had titles like "Don't Edit Me Out," or "Don't Edit My Brother Out," or "Don't Edit My Child Out." And I think it's important to think, for us to recognize the distinction between conditions that we think of as disease and whether people consider them to be separable aspects of themselves that they would be happy to slough off, and could be sloughed off, if you will, or what kinds of ways of being in the world. I keep wanting to use that term because it's not so toxic as all the rest of the ways we talk about disability and illness, and how much of those diverse ways are understood as part of who we really are. So the people that I know who, many of the people I know who are deaf, who are blind, who have autism, let's say, just use these iconic conditions, if you will, don't think of those qualities, those ways, as being things about themselves, like that they, like, you know, hair or accessories that they could get rid of and then they would be the way they wanted to be. They actually conceive of these ways as being constituent of who they are and how they live in the world and relate to other people. And I think that's what we want to try to think about, what those differences might be.
Thank you. Well, thank you all. Thank you for your passion, your perspective, your commitment to the issue, and the diversity of opinions. Please join me in thanking the panelists for a